Hello, this is Stephen-Castro, and this is going to be a short presentation on pulmonary embolism. Your reading assignment for pulmonary embolism can be found in your medical surgical book under Chapter 13, pages 616 to 624, as well as review the concept for nursing practice. And this falls under gas exchange in your concept book, and it's 178 to 187. There are a few medical terms that you should have an understanding of or should be able to define. Pulmonary embolism, obviously, hypoxemia, syncope, positive inotrope agents, embolectomy, and inferior vena cava filtration. These can be found in your medical surgical book. A couple of optional pre-class activities. Either have a written explanation or a drawing of the pathophysiology. Even though we don't test you specifically over at pathophysiology, we do incorporate it into our questions. Also, very important to list those teaching points for a client discharged on anticoagulants, because that's one of the treatment. Pulmonary embolism technically falls under the priority concept of gas exchange, because that is where the true problem lies. But the underlying concepts are perfusion and clotting. Pulmonary embolism is an emboli that's either made of a solid or liquid or an air that gets lodged in the pulmonary vessels. This leads to reduced gas exchange and reduced oxygenation and reduced perfusion. That'll lead to hypoxia and potential death if it's severe enough and uncorrected. Here's a list of risk factors that may predispose someone for a pulmonary embolism. We need to be able to identify these kinds of patients and put prevention measures in place. There is a chart, 32.1 on page 617. You should probably review that chart for prevention of pulmonary embolism. Even though PE can occur in young and otherwise healthy people, we do recognize that the primary cause of pulmonary embolism is due to venous stasis. So we are going to try to focus our nursing actions on prevention of those modifiable risk factors. Your physical assessment should revolve around the respiratory and cardiac symptoms. Those are going to be your primary focused assessments. There is a box on page 618, 32.2 with some classic signs and symptoms listed, including chest pain, shortness of breath, tachypnea, as well as that impending sense of doom. They get very anxious. Laboratory assessment would include your ABGs as well as this test called a D-dimer. Additional assessments will include vital signs, including that pulse oximetry, and some radiography assessments such as a CAT scan, a VQ scan, ultrasound, or chest x-ray. There is a genetic predisposition called factor V Leiden that will predispose a client to develop blood clots. It is an unmodifiable risk factor. Typically, this happens in young people that have no other risk factors for PEs, so they would need additional testing. Once you've collected your data, it's time to interpret that data. They have hypoxemia due to the lung perfusion mismatch, hypotension because of that shunting. You get less forward-moving blood. They have potential for excessive bleeding because of the anticoagulants, and of course, anxiety. Clients with the PE are hypoxic, so we're going to have to manage their hypoxemia, provide oxygen, put them in a proper semi-Fowler's position, do continuous cardiac monitoring, make sure they have good IV access, continuous pulse ox monitoring, and we'll also monitor for bleeding because of those anticoagulants. Just to reiterate, we do want to monitor for bleeding at least every 2 hours, if not more frequently, because of the medications clients with pulmonary embolism take for treatment, such as heparin or Lovenox. Also institute those bleeding precautions.